Okay, we will start. Today we'll talk about pacemaker mode. Okay. What is our objective? This first of all, this I will disclose, give you a disclosure that this presentation is from Medtronic Academy, but it is give all the information in a very clear way. Just to disclose this, okay. What is our objective? Describes the NBG code, list of possible pacing mode, and there is timing interval, and a lot of data, but it will be in another session, inshallah. Okay, what's mean by pacing mode? What's mean by NBG code? Okay, what's the shortcut of NBG code? This North American British Cardio Electrophysiology Association, that they agreed for this code since many times. Okay, what's mean? We have a 4 number, the basic. Okay, first letter refer to chamber paste. Okay, second letter refer to chamber that sense, and the third letter, okay, refer to the response of sensing. Okay, and the fourth letter refer to this rate modulation or no. To simplify this, that we have all of you know that there is a VVI mode, DDD mode, VDD mode. All this mode we will discuss it in brief, and to make it simple and clear. Okay, and there is a big conflict that sometimes that we called some doctor, we have a DDD pacemaker. DDD means mode, but you should call this pacemaker. We have an implantation of single chamber pacemaker or dual chamber pacemaker, single chamber ICD, dual chamber ICD, or CRT that have a third lead in the CS. Okay, this nomenclature is very important. How we differentiate between the pacemaker, single chamber or dual chamber, and differentiate between the mode. The mode, okay, that we call that is consisting of 4 letters. Okay, first letter refer to chamber paste. Okay, second letter again refer to chamber that sense. Okay, third letter refer to response of pacemaker to sensed event. Okay, and fourth letter refer to mode. So if we have a mode of VVI here, this is the ventricle. V refer to the ventricle. A refer to the atrium. D dual. Okay, S there is not used. Okay, but we have all this. O no paste. Tamam. A is atrium, refer to atrium, and V referred to ventricle. Okay, and second letter O none. A atrium, V ventricle, D dual. Third letter O means none, T triggered, I inhibited, D dual, trigger and inhibition. Okay. Fourth letter O means none, R means modulation. So if I told for anyone I have a pacemaker in a mode ODO, what's mean by ODO? Can anyone answer to me? Even if a wrong answer, no problem.
D dual pacing
Sensing both atria and ventricle.
No, ODO. The mode
Sensing
is O.
both atria and ventricle only.
Okay, sensing both atria and ventricle. Yes, clear. Very good. Okay, that this mode ODO, that no pacing. O sensing, O no pacing. D sensing in the atrium and ventricle. O, the third letter, nothing, none. Okay, so this pacemaker only that sense, okay, in mode ODO. So what mode would you use for third degree AV block? Anyone answer also?
DDD.
DDD. Okay, correct. What mode would you use for sick sinus syndrome?
AI.
AI alone or
AI with the
AIR?
DDD backup. AAI
R?
R, rate responsive.
Why?
Because the SE node is diseased, so I will pace
Yes.
it here all the time. If the patient do exercise, it will not match with his exercise. So I have to make it rate responsive means it can match, cope with the exercise of the patient,
Yes.
can increase
What
with the
the,
exercise by
yes.
sensor in the pacemaker.
Yes, this clear, okay, that when we use the R, okay, the fourth letter, okay, when we I will use it mainly in two cases, okay. The first case is sick sinus syndrome. I implant a single chamber or dual chamber pacemaker in sick sinus syndrome. That's the sinus node, okay. It cannot give the patient, okay, the required heart rate for exercise, for resting heart rate, and it is a disease. So we will implant a pacemaker in patient with sick sinus syndrome or with chronotropic incompetence. It's a part of sick sinus syndrome that this patient come with you with bradycardia, sinus bradycardia, 30, 40, but normal EV conduction, and you give him isoprenaline or atropine, the sinus node, or in stress test, the sinus node cannot match the exercise. It will reach 60 and no increase. So I put R, okay, as the pacemaker have a sensor. We'll discuss it also, okay, how to translate the effort to increase in heart rate. There is 4 types of sensors that can mimic the actual response of sinus node. In another case, we have also one case that we put in R. Can anyone told me that what is the another case that we a part of sick sinus syndrome in
If we
patient?
have chronotropic incompetence,
Yes, any VVI mode, better to put it in VVIR, okay. And in patient with permanent AF and complete heart block, we insert a single chamber pacemaker. Okay, so better to give him a VVIR, put the fourth letter R mode to mimic the actual response of the heart rate during exercise. So what mode you will use for sick sinus syndrome, AIR or DDDR? Okay, manage MVP, this protocol in Medtronic, okay, that this managed ventricular pacing. It is a mode. This it will appear to you, okay, in this letters, okay, AIR, DDD, okay. This is managed ventricular pacing. There is an algorithm, okay, that every time the pacemaker measures the conduction, okay, and if there is a normal conduction, AV conduction, it will keep the mode in AII R mode, and if there is no conduction, it will automatically, okay, change mode to DDD. This mode is not this algorithm is called managed ventricular pacing, okay. And in another companies also there is a lot of algorithms, okay, that change between AI mode and to DDD mode, and this for increasing the intrinsic activity of the heart, and also to reduce or minimize right ventricular pacing. Okay, what mode you will use for permanent AF?
VVIR. VVIR.
VVIR. VVIR. Okay. Okay. Very good. Okay, what is the rhythm and what type of device does this patient need?
VVIR. AFib.
AFib, you will implant a single chamber or dual chamber.
A single chamber with rate responsive.
Rate responsive. The mode,
VVIR.
VVIR. In this patient, you prefer, if you are the operator, I give you choice between left bundle area pacing and the conventional pacemaker. What you will decide?
Conventional pacing, if the predicted pacemaker percentage more than 40%, so it's better to do left bundle pacing, I think.
Okay, so if this patient come with this slow rate, okay, slow AFib, and most of the time he had a slow AF, and he doesn't he not in only anti rate control medication, so you prefer to put conventional or left bundle area pacing.
I think
hear
conventional.
so no, better to put a left bundle area pacing if this patient is young, and conventional pacing, it will be disappear soonly. Okay, as this patient had a very slow AF. Okay, even if it is not a young age, left bundle will minimize the synchrony, and you make the patient synchronized, not have RV induced cardiomyopathy later on. So
Okay.
this the trend every time. Okay, the science improved, and the left bundle area pacing is the new era. Okay, and in the near future, all pacing, okay, all pacemaker will depend on left bundle area pacing. It will be no conventional anymore. Okay.
Okay.
Okay. 3 basic letter, what they stand for, that I told you before. V, chamber that pace. V, second letter, chamber that sense it. And I, what to do on response to sensed beat, either inhibition or triggering. Okay, or dual. Okay, so all of you know this mode, VVI. No one of you, I think, any one of you used VVT. VVT?
No.
No. Okay. This rare, very rare to use it, and I will tell you when we use the T, it is very rarely used. But what's meant by inhibition and the triggered? Okay, so I will give you this example. Okay, here VVI mode here. If you see, pace the sense and sense the ventricle. Okay, here pacing, here pacing. Okay, here there is a sensing event. Yes. What the pacemaker will do? It is expected to pace here. Okay, but it not pace. So this inhibition of sensing, inhibition due to sensing, it will not pace, and it will create a lower rate timer again and pace after 1000 milliseconds. This is clear. What's meant by inhibition of inhibition of pacing due to sensed event. This is the letter I. Inhibition of pacing due to sensed event. It is clear.
It's clear.
something occurred, it's like atrial ectopics or something. Why he
No,
inhibits?
here the mode is VVI. It's sensed in the ventricle and paced in the ventricle, and the I, the response of sensed event. Okay, inhibition of pacing. So here there is a single chamber pacemaker. It's no, it paces in the ventricle V, and it sense in the ventricle. When it sense,
Due to intrinsic.
this intrinsic. Okay, it will pace the expected time of pacing here. It will not pace as it already sense. Okay, that's mean I inhibition of pacing due to sensed event, and it will create a lower rate limit timer and start to pacing after the timer. That means 1000 milliseconds. Okay, here it will pace again after that. It is clear?
Yes.
Clear or not? Clear. Yes. What is mean if I put the VVT, not I? Okay. We will use this mode in only one event. Okay. If I have over sensing in the ventricle. Okay. If this patient come to you and you notice that this patient had no intrinsic at all, but there is over sensing here. It is not an actual beat. Okay, it is not an actual beat. Okay, it is a noise, and this patient come to you with syncope. Okay, because of inhibition of pacing, he was in VVI mode, and this beat, it is not a true beat. It is a over sensing beat. It is a noise in the RV lead, and you are convinced that it is not a true beat. It is a noise that inhibit of the pacing. So I will make it temporary to VVT mode, that triggering that. I will inform that the pacemaker that if you are sure that this it is not an true intrinsic rhythm, okay, it is a noise. Okay, it change the mood to T, that trigger when it sees this noise, it will pace here. Okay, trigger to inhibit the RV lead noise. Okay, you will really we use this term, this mode. Okay, only case we will use it in VVT mode, that if you sense an event that it is not right event, it is over sensing or noise, I will inform the pacemaker T that trigger pacing, not inhibit the pacing. Clear or no?
Yes, clear.
Clear. Okay, but when anyone asks me what's mean by dual T in the dual pacemaker, dual chamber pacemaker in DDD mode, it is trigger after sensing the atrial activity, trigger pacing. Okay, clear or no?
Regarding to the DD.
If I choose T in a VVI mode, in VV in single chamber pacemaker, when I put VVT, okay, T that trigger, okay, that I inform the pacemaker that if you feel RV lead noise, okay,
yes, over trigger. Yes, but in DDD mode,
it will track. D means tracking. Okay.
Yes. Okay.
Okay.
Tracking.
Clear.
Okay.
Yes.
Okay. Here that VVI example here, chamber pace ventricle, chamber sense ventricle, response to sensing inhibition. What's mean here? That inhibition of pacing. Okay. if it see a sensitive event, a sensitive event, it will inhibit the next pace like this. Okay. In VOO mode, what's mean by VOO mode? V,
Basing, ignoring the intrinsic.
yes, no sensing. It will pace, asynchronous pacing.
Fixed rate of pacing, ignore the intrinsic.
The intrinsic at all. Okay, here no sensing at all, so it will pace only. And in a fixed mode, in a fixed rate, so the intrinsic event here, it is not triggered, it is not inhibition. Okay, and the mode here, the rate is constant. Okay, this in VOO mode. When we will use this mode?
We use this mode actually if the patient is going for procedure, high incidence of electromagnetic interference, and the patient is dependent on pacemaker.
Yes.
Like surgery, MRI,
okay,
near the pacemaker.
Okay, this very correct. Okay, this I will inform that the pacemaker not to sense anything. It will pace, and I will before I change this mode, I activate this mode. I will check for intrinsic rhythm. Okay, if there is an intrinsic rhythm, I should make the rate above the intrinsic rhythm. Okay, if there is intrinsic rhythm about 40, 50, sometimes it will reach 60, and I will give the patient to go for surgery, so I will make it 70, lower rate limit in VOO mode. Not to, this is clear, to overdrive the heart and not make any chance of intrinsic to be appear. Okay, this is point is clear. Clear?
Yes.
Yes. Okay. What is the risk? What type of device does this patient need?
سأنس برادي.
Okay. What is
يا
the
دكتور مسلم.
نعم. ايوه اتفضل. الو. الو. You hear me? سامعني؟
Yes.
Yes.
Okay. What type of device does this patient need?
DDR.
Hmm?
DDR.
VVR.
DDR.
DDR. طب for example, this patient, you see that
If this patient
silent
had
disease.
chronotropic competent, no need, I think.
Okay, we can use DDD. Okay, and also we can use AI single chamber pacemaker. If I put a dual chamber pacemaker, the mode, what you will activate the mode in
AAIR.
AAIR versus DDD. But here is very short PR. It is normal PR interval. Okay, so we don't need to give him an RV pacing. He doesn't need. Okay, so we will activate the mode AAIR. Okay, versus DDD. Okay, or another in another companies, we like St. Jude and Boston, we will increase the EV delay and promote, activate another feature that VIP or any feature or Rhythm Plus to promote intrinsic conduction. But anyway, he need pacing in the atrium mainly, okay, and he need also the R.
Can you repeat
اتفضل.
Doctor, can you repeat the last ECG, please?
Hmm?
The last ECG, please. and experimental.
Here,
Yeah.
this one or this one? Yeah.
No, it's sinus brady. Yes.
Yes.
Yes, this.
Yes.
I think this patient, if the patient is chronotropic competent, do you think any need for device?
Is chronotropic this if we calculate this rate 1, 2, 3, 4, 5, 6, 7, 8.
Around 40 or
If you want to do a stress ECG for him, yes.
Yes, exactly.
Yes. Okay. So this clinical scenario, I agree with you. Okay. If this patient had chronotropic competence, and also he had on the rest no symptoms at all.
Okay.
Okay.
No need for device at that situation.
But this is very low rate. Okay, and you should evaluate this patient clinically very good to decide not to insert a pacemaker. Okay.
Okay.
On another
Okay.
session, on another thing also, if this patient, what you will do if he is symptomatic, chronotropic, he had chronotropic content, okay, but is symptomatic during this heart rate, okay, what you will do rather than pacemaker?
something like tests.
No, intervention. What you will think about this patient?
Yes, ablation of cardioneural ablation.
Cardioneural ablation. You should
Yes.
exclude that this is not a sick sinus syndrome. If you are sure that, and they do a head up tilt and test this patient to exclude the high vagal tone, and if this patient is young, okay, and he had a cardio inhibitory syncope during head up tilt with pause, okay, this patient will benefit more from cardio neuro ablation. Okay.
Okay.
تمام.
تمام.
AI mode, the same like VV, but it will pace in the ventricle, sense in the atrium, and inhibition to sense an event in the atrium. Okay, here it will pace atrial pace. AP means atrial pace, and activate the lower rate timer. Okay, and then atrial pace again. Okay. What is the reason? What type of the device does this patient need?
This is Brady. Why B wave not related to QRS, like complete heart block.
Complete heart block. Yes. Clear. Okay. The mood.
DDD.
DDD. R or no?
DDDR. Yes.
DDR or no?
I don't know.
No. If you feel the sinus risk, clear. You don't know. Actually, you don't know. That's true. Okay. And you insert the pacemaker, and during follow up, if you have a sinus risk, clear, and you will go for histogram in pacemaker during interrogation, and you find that patient had a rate response very well, intrinsic rate response well. Okay, so you will not activate the R. If you feel that patient had in the rate histogram in the pacemaker, you find this patient almost at 60, and there is an atrial pace at 60 beat per minute is too much, like 70 or 80% of atrial pace at 60. Okay, so you will activate the R. Okay, this during routine follow up.
Yes, so we will activate the R if the patient completely dependent.
Dependent on atrial pacing.
Yes.
On atrial pacing. Okay.
Okay. Atrial.
Okay. Here the mode DDD. Okay. D sense and pace in both chamber when needed. Okay. Atrial pace, ventricular sense, atrial sense, ventricular pace. Okay. Accordingly, it will sense in pace in both atrium and ventricle, sense in both atrium and ventricle, and inhibition and the triggering according to both chamber. Okay.
And I have a question here.
Okay.
The lower rate limit or lower
Mm.
rate interval in the past in the past slide, please. Yes, it depends
Here.
on the atria or ventricle. يعني the pacemaker will start to count
In pause.
in
pause. In pause.
Okay.
What's mean by pause? Okay. So if if the patient had heart rate of 50 and I adjust lower rate limit on 60, okay, it will pace in atrium. Okay.
Okay.
And then after that, okay, it will activate the pacemaker timing named paced AV delay. Okay, as it paced in the ventricle, it will activate the timer paced AV delay. Okay, for example, I will adjust it around 180 millisecond, and after that, if there is no intrinsic risk, it will pace in the ventricle. Okay.
Okay.
And it will take the same manner every beat. Okay, if it senses an atrial event more than 60 beats per minute, okay, it will inhibit pacing in the atrium, and it activates the sensed EV delay. Okay, and we will wait for intrinsic rhythm during this sensed EV delay. If there is sensed event, okay, it will activate the timer again. Okay, and it will run between atrium and ventricle. Okay, this in pacemaker timing. Okay, it will understand it more. Okay, but this is a brief that you in the timing it will depend in pause.
Thank you.
Okay. Okay, label each ECG with the phases of pacing: A sense, B sense, A pace, B sense, A pace, B pace, A sense. First ECG. What do you think? A sense, V pace, E pace, V pace, A pace, V sense.
A
A sense,
sense,
V sense.
A sense, B pace.
A sense, V pace. P here.
A pace, V pace.
A pace, V pace. C.
A sense, V sense.
Okay. D.
A pace, V sense.
Okay. Very good. Okay. What's mean by magnet?
المسلم.
نعم.
نكتب ولا نقول
نكتب ولا نقول في ايه؟
الصور
ديت نقول يا جواد.
يلا picture A or let A, it's A sense V base. The second A base B sense. This is okay. C A sense B sense C.
وبي
D B A base V base B.
Okay.
Both base.
Yeah.
D A base V sense.
Okay, very good. Now we will talk about magnet application. When you will use a magnet in the pacemaker, anyone can answer?
And pacemaker mediated tachycardia maybe.
Maybe it's correct.
Put the
Okay, what will happen if you put a magnet on the pacemaker?
it will change the mode to V, I think.
To what?
VOO.
It will change the mode either in single chamber pacemaker, chamber pacemaker VOO, okay, or AOO if in single chamber pacemaker in the atrium alone, okay. In dual chamber pacemaker, it changes the mode to DOO, okay. This is when you put the magnet on the pacemaker, and when you put the magnet in the pacemaker, you will check the longevity of the pacemaker. If you don't, the patient come to you with in your clinic and he doesn't know which type of pacemaker he had. Okay, he didn't know. You put a magnet, and according to the rate, okay, just when you put a magnet, there is all pacemaker, okay, all manufacturer have a two rate. Okay, rate indicates that this battery is normal battery, not at end of life. Okay, and the other rate, it will slower rate. It indicates that this battery at end of life or need to be replaced. Okay, when
So
you put a magnet,
the patient will sense as a dizziness or a near syncope if that, yes, you will sense syncope if the battery is near life or near to end.
yes, he will at end of life or need to be replaced. Okay, it will base
I mean the
lower rate.
symptom, the same. Yes,
The
the symptom.
symptoms,
What we will. Yes, the patient. If
the patient,
when I put the magnet and
magnet will increase the rate anytime. Okay, if you put a magnet, every manufacturer, يعني Medtronic, if at the beginning of life it will pace at 85 beat per minute. Okay, or elective recommended replacement time, it will pace at 65. In St. Jude, like 80 and 60, Boston 95, 70. Okay, there is a table. Okay, clarify the pacing rate for every company. Okay, at the beginning of life and at recommended replacement time. Okay.
my question, doctor, يعني if I put the magnet on the patient and patient feel dizziness or near syncope, this is mean the battery is end of life, yes?
No.
يعني لو حس
No, 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 no. You will depend on the rate.
مشكور. Okay.
On the rate.
Yes, depend on the rate.
On the rate. Okay. Instead of the lead is good and the post lead are good. Okay. And when you put the magnet, the first interval it will pace in high amplitude and then decreasing the amplitude. Okay.
Okay.
And you notice it when you put in Medtronic wand is a magnet. When you put a Medtronic wand on the pacemaker, you will notice that there is atrial pace, ventricular pace. Okay, atrial pace, ventricular pace. Even the patient had intrinsic rhythm. Because when you put a magnet on any pacemaker and the wand of Medtronic and the wand of Biotronic, both are magnet. And there is a magnet inside the circle of the wand of St. Jude, but it will be in another on the back of the programmer. Okay, that's the wand of Abbott, it is a circle. Okay, and there is a magnet inside this circle, but it most of the time removed and put on the back of the program. Okay, clear يا جماعة؟ نكمل. We'll continue.
Okay. Continue.
Okay.
Okay.
The fourth letter R. Okay. What does the heart rate do when you exercise? R means rate response, and all of you understanding the rate response. But anyone, can you imagine how pacemaker know that this patient will exercise?
Yes. certain sensor in the pacemaker can measure the impedance of the chest wall and during respiration, respiratory rate. Yeah, if there is acceleration of the respiration
Yes, we will
and the
discuss the
impedance
type
of the
of sensor.
thoracic. Yes.
There is 4 type of sensor, okay, or 5 types. First type, the activity. It is mechanical vibration, okay, mechanical vibration. It will sense any vibration on the chest mechanically, okay, and when this vibration is decreased, it will stop. Well, if vibration is increased, okay, it will activate the rate. Accelerometer, body acceleration. It is a sensor that senses the body acceleration itself, okay, and there is minute ventilation transthoracic impedance. It will measure the transthoracic impedance. And fourth one is QT interval. It will measure the QT, okay. And the last one is closed loop stimulation. And this sensor, it is use this closed loop stimulation. It is very useful in rate drop response feature in the pacemaker, not rate modulation. Okay, there is a difference between rate modulation that are this are in NPG code, and there is feature in the pacemaker called rate drop response. The most effective sensor in rate drop response is closed loop stimulation. Okay, you understand what's the difference between rate modulation and rate drop response?
Repeat, please, Mr. Doctor.
I will clarify it clear. Okay, we have already an MBG code. Okay, this are VVIR, DDR. This is a rate response. And we already explain what we will when we will use this rate response. Okay, clear? This rate response depend on this, or this one, or most of companies will have a 2 sensors, depend on 2 sensor in every pacemaker, not 1 sensor alone. Okay, but there is feature in not in all pacemaker called a rate drop response. What's mean by rate drop response? It is a feature. So you have a patient have a DDR mode, but this feature is not in the pacemaker. That feature of rate drop response not included in the pacemaker. Okay, this feature we activated in patient with vasovagal syncope. Okay, that sudden drop of heart rate. Okay, this feature will do, it will sense the sudden drop, or this sudden drop, it calculated by drop size on heart rate, and it will pace for 1 or 2 minutes in high heart rate. All these parameters are adjustable. Okay, but it is a feature called rate drop response. This feature, the most effective sensor of the in this feature is closed loop stimulation. Clear? You know how to differentiate between the R in NPG code and the rate drop response feature? شباب.
Yes.
كلير النقطة دي كلير ولا في حد مش فاهمها؟ اللي مش فاهمها يقول لي، او مش فاهمها خلاص اكيد ما قلتهاش. تمام؟ If you all understand what difference between the rate modulation and the rate drop response feature, Okay. If you anyone want to repeat it again, tell me please. Hello. سامعني؟
I think, hello, I think from what I've understood is if a patient has a sudden drop in the intrinsic heart rate, the device will be able to
Yes,
sense
this
it.
if there is a sudden drop in the heart rate in vasovagal syncope, okay, I will activate the rate drop response feature. Okay, rate drop response feature. What this feature do? It will I will adjust it according to two items. If the patient had a lower rate, I will inform the pacemaker. If you reach 70 beat per minute or 60 beat per minute, please it will pace at a rate of 95 or 100, okay, for 1 minute or 2 minutes to protect the patient from the vasovagal syncope. Okay, this is the feature. This is called rate drop response feature. Okay, but the rate are in NBG code if the patient had a DDDR mode, R mode, okay, and the patient had no intrinsic, and patient move, the heart rate will increase according to his activity to reach 100, and when he stop his activity, the rate goes slower to reach the lower rate limit again. This is the R, fourth letter in the NBG code mode that mimic the intrinsic activity of the heart. But the feature called rate drop response feature, it will monitor the heart if there is if the patient had intrinsic A sense V pace, okay, or A sense V sense at 100 beat per minute, and during tilt table the heart rate will decrease to be 60 or 40, okay. The rate drop response will notice this. I will adjust if you feel that there is sudden drop of heart rate from 100 to 70, okay, pace at 100 or 110, okay, for 2 minutes, for 1 minute, to protect the patient from vasovagal syncope. This is the rate drop response feature. You understand?
Okay.
Yes.
Clear? Very clear. Yes?
Yes, it
Yes,
is
clear.
clear.
Okay. What mode does a dual chamber pacemaker change when a magnet is applied? VVI?
DO.
DO. Okay.
Yo,
DO. Good. Okay. Here, this is a timing cycle. It will be discussed in another lecture. Okay. We finished. Anyone have any question?
Thanks.
thank you. Thank you.
Okay. Who will?
Thank you, Dr. Mohamed.
Welcome. You are welcome. Thank you. Okay. Who will present a cases?
I was supposed to present a case. Maybe
Okay.
I can share my screen, but I think
Okay.
you have
I do.
discussed most of the things that the case was highlighting. So I think it will be a quick presentation.
Okay. I will stop share. Okay.
Okay.
I already stopped share.
I don't know if you can see my screen.
We are seeing your screen.
Okay.
Okay.
So I'll start off. This is a case that came to our clinic some years back. a 25-year-old patient who had been referred for cardiac evaluation. And she came to us around 1 week after cesarean section delivery at a different facility. And the main reason for referral was to evaluate her heart rate, as during the intra-op period, they noticed that her heart rate was low around, the referral note mentioned a range of between 40 to 45. The patient was completely asymptomatic, and on further probing, she reported that during her previous pregnancy, which was 3 years ago, there was she underwent a cesarean section, and at that time there was mention that her heart rate was low, but no further evaluations were done. So at the time of presentation, as I mentioned, she was completely asymptomatic. Her blood pressure was 138/74, and her heart rate was 42. So we went ahead and did an ECG. I don't know whether anyone would like to comment on this ECG. Feel free to contribute.
It's a third-degree AV block.
Yes, so we made a diagnosis of complete heart block in a 25-year-old lady. We tried to look for any reversible causes. Her echo was normal. Her baseline lab tests, including electrolytes, were within normal range. And we also did an autoimmune screen, which was negative. So we could not really identify any obvious reversible cause. The next step was to implant a pacemaker, given that she had complete heart block. So I think we've already discussed, this is a 25-year-old sinus rhythm in complete heart block with normal LV function. She's quite young, so we expect lifelong pacing. Maybe anyone can just quickly mention which mode they would choose when they're implanting the pacemaker and why. So these are the options.
I think the answer is F, DDG, and conduction system pacing, because the patient is young.
Yes, exactly. Because the patient is young, we expect, I think we've already gone through this, so let me not repeat, because Dr. Mohamed has done a very fantastic job. But given that she's a young patient, we expect high pacing burden because she has complete AV block. Dr. Mohamed has already mentioned that we are slowly moving away from conventional pacing to more physiologic pacing. And maybe just to get back to the mode again, would anyone automatically put the mode as DDR at this particular time for this patient? Maybe Dr. Mohamed can clarify, but I think from the talk that you've given, you said sometimes it's difficult to know, but during follow-up, when we are assessing the EGMs on interrogation, when we look at the rate histograms, we can make that call. But maybe you can clarify for us whether we need to implant the R at this, to select the mode with an R at the time of implantation or not.
Actually, doctor, we don't need to R at the time of implantation, okay? Instead of that this patient has a sinus rhythm, no sinus node dysfunction, and heart rate is actually more than 60 or 70, so no need to put R at the time of implantation.
Thank you.
Okay.
So we've already mentioned that years later during follow-up, she was progressing well. She did not have any symptoms, but her main concern was she noticed that the heart rate on her smartwatch had changed a couple of months from a baseline of 60s to now 90 to around 110. So she was not sure what was going on and needed a bit of advice regarding that. So we did an ECG, and this is what it showed. Anyone can comment on the ECG?
Right bundle branch pathology with BVCs. Right bundle.
Okay.
Yes, white QRS.
Yes.
Yes. Maybe.
And the rhythm?
And
This
there is
this is look like fibrillatory waves.
Exactly. So the rhythm was now in atrial fibrillation, which was the main thing I wanted to highlight. So what, in such cases, what should we expect the device to do? So we're wondering, should we change the mode at this particular time? Do we add rate adaptation? So maybe people can just comment on what they will do for this particular patient at this time.
I think we have to do rate limiting for to not tracking the atria.
Okay.
The II mode to allow the pacemaker to not tracking the high rate of atria. So
when we did the interrogation, sorry, I don't have the EGMs at this particular time. The device had automatically done a mode switch. It had changed the mode automatically because I think with the atrial fibrillation we didn't want it to track, and in this tachycardia. So in terms of now the next steps for this patient, should we switch off the atrial lead completely? Do we add rate adaptation because now she has atrial fibrillation? I'm also not sure, so maybe Dr. Mohamed can also assist.
Yes. In this patient, we should interrogate the pacemaker, okay, and see sometimes this fibrillatory wave are not be sensed very well in the atrium. But you told that already the heart rate, there is an automatic mode switch, and they change the mode to VVIR, okay. And we will adjust the rate response for this patient. If already this patient there is an automatic mode switch and change it to VVIR, okay, and this heart rate is very high, 90 to 70, we will adjust the parameter of rate response, okay, accordingly to adjust it according to the patient need. There is a sensitivity of this rate response, make it a very fast response, make it slow or medium response, okay, and we will adjust the parameter of rate response itself inside during interrogation of the pacemaker, okay.
Okay.
And actually, she need a rate, but why it is in 110? Okay, already it will be on 110. Okay, the mode in this patient it changed to VVIR mode already. Okay, if not, it changed to if it changed to VVI alone, it will pace at lower rate. Okay. It will pace at a lower rate limit, okay, as there is no R and there is no sensing, okay, as you all the rhythm is AFib with V pacing, okay, so the rate response is activated, but we need to adjust the rate response parameter, okay, not to make it at all the time 90 or 110. There is a very sensitive, okay, to the rate response is very sensitive, okay, so we will adjust the rate response parameter, okay, but already in this time in this ECG the rate response is activated but needed to be adjusted. Okay.
Yes.
Okay.
So would our answers change if this patient was a little bit older, 75 years instead of 25? Would we still choose the same mode? What do the rest of the team think?
And also, I will. Anyone you want to change a mood to or to do another thing? What do you think? Clinically, in this patient,
Repeat the question, please, doctor.
what this patient, it is a 25-year-old female patient, pregnant, and we discovered a complete heart block with sinus rhythm, and we implanted a dual chamber pacemaker. And after that, she presented to you, okay, with a AF, okay, with heart rate is 90 or 110. Okay, what you will do, okay, clinically for this patient, it change the mood. We will
yes, and medically, maybe give drugs like cortisone or something like anticoagulation.
Yes. In this young patient, we should cardiovert here, okay, not to keep here in atrial fibrillation, okay. We will not. We will for this patient. You should start anticoagulation. You should start a rhythm control. Okay, not to judge this patient for her life to be permanent or to keep her in a very long time in AF. Okay, clinically you should try to cardiovert this patient to restore her sinus rhythm. This is clinical wise, okay. But if we will talk in adjustable parameter, we will go, okay. But if any patient come to you with this is very young patient, even an old patient, okay, and you notice that pacemaker will told you that the AF occurred at day, at time, and how many days, or how many hours, how many minutes this patient had an AF. Okay, so clinical wise, you should do rhythm control for her. If she need an anticoagulation, she will take anticoagulation. Anyway, she will take anticoagulation even if you decide to cardiovert her and Chad Vasque score 0. Okay, you will give her anticoagulation until you cardiovert her, and you will continue anticoagulation for 1 month, and then we will discuss how to adjust parameter. Okay.
Sir, I have a question because I received call that interrupted the lecture. Why the based rhythm is the right bundle? Is it
maybe it is a left bundle area pacing? Okay. Left bundle area pacing. It will make a right bundle like this.
Okay.
And maybe this. Yeah. Okay. Okay. We can continue. Yes.
So I think this is just a different case that I got from the internet. The last case, a 70-year-old had BVI implanted 3 months prior.
You continue the case 1. We finished the case 1.
Yes, we finished case 1.
Okay.
Only one question, Dr. Mossallami. Can we give DC on patient on pacemaker? Can we cardiovert by electric cardioversion?
Yes. Yes.
Okay.
In normal position.
Okay.
If you not cardiovert, make an anteposterior, but in normal position you can cardiovert. Yes.
One more question, Dr. Mossallami.
Yes.
If the patient AF and let's say the heart rate more than 100, shall we put the mode VVI without R or keep it VVIR?
Yes, it is very good question. If the patient has had an AF of 100, what you will expect? This is paced rhythm or intrinsic rhythm?
Paced rhythm.
Paced rhythm 100, you should adjust the parameter of rate response. You understand? Okay. You
So
understand?
keep it.
But you should adjust the parameter of rate response of R. Okay. It will the pacemaker. Okay. If the patient had an AF with intrinsic rhythm more than 60, okay, the pacemaker in VVI mode, and you adjust the lower rate limit to 60, and patient had intrinsic rhythm above the 60, the pacemaker will not pace, or will do
Yes.
an intrinsic and intermittent pacing, okay, as AF is irregular, okay. But if you found the patient come with you, okay, with VVIR mode, okay, with paced rhythm in AF 100, okay, and the lower rate limit you put it like 60, you should adjust the rate response parameter. What will make the pacemaker pace in 100? Only rate response in AF.
Okay, thank you.
Okay, you understand?
Yes.
Yes.
Okay, so you will adjust the rate response parameter, okay, and make it less sensitive, okay, and adjust it to 100, 190 if the patient is complaining with this high heart rate. Okay.
So this is the last slide. A 70-year-old VVI implanted 3 months ago comes back complaining of fatigue, dizziness, neck pounding. Maybe someone can just comment on the ECG and what they will do at this stage.
Okay, the ECG is left bundle due to pacemaker, but I see inappropriate spike. I mean, it's like under sensing. Some spike comes after the QRS.
Okay.
No, I
Anyone
think
else?
this is not a spike. I think this is the mark of in between the leads. This
okay.
arrow, I think it indicate retrograde B.
Yes.
Yeah.
Okay. Retrograde B after the based. Sorry.
No. Okay. Complete, doctor. Sorry.
Yeah, I think there is retrograde B. This may trigger pacemakers. She has neck pounding, congested neck vein.
Yeah. So
There
just
may
wanted
be
to highlight.
pacemaker syndrome. Pacemaker syndrome if the atria and the ventricle at the same time.
Yeah.
Atria is contracted enclosed with closed valve, maybe lead to pacemaker syndrome, congestion, and heart failure-like symptoms.
Yes. Actually,
Right?
just wanted to highlight the retrograde P waves that the arrows are indicating, and the ventricles are paced. So yes, this is a case of pacemaker syndrome, as you've clearly said. And what will you do in terms of the next step? The mode is VVI.
But this patient had a single chamber or dual chamber pacemaker.
So that dual chamber pacemaker.
Okay, so what? This is very easy. We solve this mode.
Increase
Yeah,
refractory periods.
This is very easy. It is a tick.
Increase the BVAR.
This patient had a dual chamber pacemaker. Yes.
Okay.
Yes.
Yes, and the
No,
mode,
but the mode
is VVI
selected
mode.
was, yes.
So in the question, we showed a dual chamber pacemaker implanted 3 months ago with a mode adjusted to mode of VVI mode. And
Yes.
this patient had a pacemaker syndrome. And it is very easy to solve this problem of this patient. And this patient will have a dramatic response when you just change the mode from VVI to DDD, as patient had retrograde B. Okay, so this patient has a sinus rhythm. Okay, so you just change the mode from VVI, okay, to DDD. Okay, the patient he will hug you and kiss you, okay, that you changed his life.
Okay, thank you. This is my last slide. Thank you.
Thank you. Thank you so much.
Okay. Thank you, Doc. Thank you so
Dr.
much. Very
Thank
good
you,
presentation.
Dr.
Excellent.
Mohamed. Thank you.
Excellent. Any question?
Thank you,
Thank
Dr.
you.
Mohammed.
Thank you. Thank you. Okay. We finish, okay?